Hello, and welcome to Ask a Clinician on Wondering Wednesday of BFRB's Awareness Week 2022. I'm Suzanne Mouton-Odum, TLC's Board and Scientific Advisory Board Vice President. Some quick housekeeping items before we get started. This is an educational webinar offered in a safe and welcoming environment for everyone attending today, so let's keep it that way. Questions for the panelists should be asked through the Q&A feature, not the chat, please. Questions will be answered at the end of the presentation. Leading our discussion today are two experts in the field of body-focused repetitive behaviors, Dr. Charles Mansueto and Dr. Fred Penzel. Dr. Charles, or Charlie Mansueto, is founder and director of the Behavior Therapy Center of Greater Washington in Silver Spring, Maryland, where he's been involved in the study and treatment of hundreds of BFRB sufferers. I would say thousands, maybe even. He's a founding member of TLC's Scientific Advisory Board and also serves on the scientific advisory boards of the OCD Foundation and the Tourette Syndrome Association of Greater Washington. He's a past professor of psychology at Bowie State University, Maryland, and is on the clinical faculty of the American School of Professional Psychology of Agorcia University, Virginia. He chaired the first national symposium on trichotillomania in 1990 and continues to investigate, publish, and speak about the disorder. Dr. Fred Penzel is a licensed psychologist who specialized in the treatment of trichotillomania and obsessive compulsive disorders since 1982. He's the executive director of Western Suffolk Psychological Services in Huntington, Long Island, New York, a private treatment group specializing in trichotillomania and OC-related problems. He's the author of several books related to hair pulling and OCD disorders. Dr. Penzel is a founding member of TLC's Scientific Advisory Board and currently serves on the board and SAB secretary, and as a senior faculty member of TLC's Professional Training Institute. So welcome, Charlie and Fred, who I'm proud to say are both dear friends of mine. And we are going to lead off this discussion with just clear the slate with some obvious questions. So guys, what are BFRBs? Let's just put it out there. Charlie, you want to start? What are BFRBs?
Well, BFRBs are a category, a mouthful, actually. Nobody loves that term, but there's been a long-standing recognition that hair pulling is a disorder. It does disrupt lives. It makes people very unhappy. And so that was one that was included in the American Psychiatric Association's diagnostic manual. Later on, it was clear that skin picking also deserved to be in there. Prior, it had been just a part of the dermatological literature, but it was made a disorder, I think it was in 2013, largely at the lead of the Scientific Advisory Board of TLC. Good going, guys. Now there are two things that are recognized as disorders under the title of BFRB, body-focused repetitive behaviors. And what they tell you is that there is a continued and repetitive focus on the body in such a way that it causes damage. And this damage can almost be a chain reaction, that damage begets further damage. Those sorts of patterns are what is captured by the term BFRBs. And we recognize that there may be others as well as the two official ones. For example, biting the inside of the mouth, or the tongue, of the cheeks, the lips, peeling away skin on the lips, and so forth. And even others that sometimes are brought in that may or may not be closely related to skin picking and hair pulling, like teeth grinding and so forth. So it's an umbrella term. It's clearly defined for two of the disorders, but it ropes in some other ways that people get into trouble with repetitive focus on body tissues and behaviors that cause them damage.
Thank you. That's a great explanation. Do you have anything to add, Fred?
Yeah, I would say that it's these problems are more widespread than most people recognize. They're also seen in animals, actually, too, various forms of these, or what we believe is happening in animals. My own belief is that it's like an external attempt to regulate what's going on internally in the central nervous system, basically, in terms of stimulation, that people do these things when they're overstimulated and understimulated, and that can take in a whole variety of behaviors because there's so many different parts of the body and so many activities that can serve the purpose of either giving a person increased stimulation when they're understimulated or reducing stimulation when they're feeling overstimulated. It seems to be like a balancing act basically. But and I would also add that these are, in general, a lot of stigma attached to these things. These are disorders that involve a lot of shame on the part of sufferers, and in addition, it's also a great deal of isolation, and which is what's great about like what we're doing today, basically showing people that they're not alone, and that there is help for this, and that they don't have to feel less than anyone else on account of having these behaviors, since no one asks for it.
Yeah, those are really great points to add, Fred. And it really speaks to, you know, understanding, as you pointed out, sort of the regulation, the self-regulatory aspects of hair pulling and skin picking and other BFRBs. One question that comes up commonly is sort of what causes people to engage in these behaviors. I think you touched on that, but this is a question that we always get, like, what is it my fault? Is it, this is something I'm doing to myself or my child is doing to themselves? What do we know about that causes BFRBs? Why would a person do this?
Mhm. Well,
Who,
I could start, we could go back and forth maybe, and
Sure.
next one, right, so, but so what causes it? Like with many disorders, many common problems associated with being human, we don't have a wonderful understanding of causation. Why do some people get this? Why do other people not get it? However, there's a general belief that there are two major factors that contribute to the occurrence of BFRBs or any other disorder. One is perhaps a constitutional vulnerability. In other words, it may be that not everyone who's born is equally prone to different kinds of disorders. For example, we know that certain conditions like alcoholism runs in certain families along certain ethnic groups and so forth, and less so in other ones. So there's perhaps a vulnerability or an area of challenge for those individuals. But secondly, we know from twin studies and others that it's not automatically so that once one genes that one is born with automatically translates to these disorders. So it looks like certain environmental experiences, certain individual characteristics now interplay with the experiences of the individual over their life. And that for some individuals, some persons get caught up in repetitive patterns, problematic patterns. That can be said of a number of behaviors, overeating or whatever, but shopping too much or whatever. But however, we are focusing on BFRBs. So it's considered a neuropsychiatric disorder. We do believe that there's something awry in the nervous system of the individuals. Where that comes from, that awryness, looks like it probably is a combination, as I said, between the ingredients that a person is born with and their experiences over time. And that's the best we can do now until we learn more about this disorder and other disorders that are in the books. Fred, pick that up.
I would agree with that. I think that there's probably some kind of an underlying predisposition that some people have, and we're still working on trying to find out what that is. I mean, there's a lot of suspicion that it may be genetic. I know in my own work over the years, I've seen it run in families, and on the other hand, I've also seen people come up with it who really can't identify any relatives who are close to them who also have this. But it may be a factor certainly for some people. Some, as we like to say, some things are true for some people some of the time under certain conditions and all. But I think if you take someone who's prone to having some of this and you put them in the right circumstances and these things just sort of come together, that's how these things occur.
Sure. Well, I think that there are some myths that probably we need to bust right now. And because we don't know, right? We think there's a genetic predisposition, but there's some environmental factors that may be at play. A lot of people wonder, is this the result of bad parenting? Is this the result of some sort of sexual abuse or trauma? Or is this the result of a self-hatred, or is this self-mutilation? So maybe you guys could speak to that. Like, do we know anything about that? Are these factors that we need to be concerned about, or are these myths we need to bust?
Well, if I can say, I would say that there are causes and there are effects. Basically, it's like sort of a chicken and egg sort of a thing. But I think that basically we see. I mean, if like for instance, let's say if bad parenting caused these problems, I think we would see a direct connection between these things in our work. And I've seen plenty of people who come from absolutely wonderful homes with great parenting and terrific conditions that they're raised under with every advantage, and all who have the same exact behaviors as maybe people who haven't come from such wonderful backgrounds, for instance. So we might say that these things in certain people's cases can contribute to the development of a problem, but we can't identify them as the underlying cause. I don't think we have any evidence that really points to that at all. Obviously, we can say that if somebody's grown up under bad circumstances, it's certainly going to aggravate a number of possible underlying conditions, but we can't really say that therefore, because it occurred together with these things, that it was the cause. We can say it could be a contributing factor, certainly, but I don't think anything at the present time that we know allows us to to make a claim like that. In fact, this is why we're pushing so hard for research to be able to identify contributing factors and causes both.
Yeah. Well, and if that were the case that trauma or sexual abuse or bad parenting caused hair pulling and skin picking, we would see that in families of kids that were treated badly, we would see a higher incidence of it. And I don't think that we do. I see plenty of kids that come out of difficult situations that don't pull their hair and pick their skin. So that's a really good point. So let's talk a little bit about treatment. What a common question that's come up in the community, and certainly for this Ask the Experts panel, is what are the best treatments, or what is the best treatment for BFRBs? What do people need to be doing that have BFRBs to help themselves?
Yeah. At this point in history, it looks like there are two approaches that stand above any others. I mean, we hear about reports of this kind of this individual who has been helped by some obscure technique or device or whatever. But in general, science the scientific approach has looked at two sources as probably the most promising. Foremost among these are learning-based treatments. There seem to be so many connections in BFRBs, so many indications that the learning process is shaping the development of these problems into life practices, very, part of the interwoven with the fabric of a person's life. So learning-based treatments are looking at those connections and attempting to disengage those connections using principles of learning, which have been well established over the course of the last century. So psychologists have been working very hard to understand how behaviors get established and broken up and left behind, how thinking about things develops, and how thoughts and values and beliefs can be changed over time. Feelings as well, all three, behavior patterns, feelings, and thinking patterns, all seem to be involved in these disorders, and using principles of learning in a concerted effort to change these three fundamental functions seems to be the best approach. A secondary approach, and of course the one that everybody is waiting for, is the magic bullet. Can we find a chemical solution or some medical intervention, physical intervention that eliminates these problems once and for all? Well, everyone hopes for that. The point is that we're not there yet. There are some promising, some interesting possibilities that are up, some interesting hypotheses or guesses or theories about ways of approaching that. But right now, it's still in the forming a better answer to the question: what kinds of medicines can help with these things? What kind of diets, what things that we do to ourselves physically can alter these? But again, the most promising of the techniques relies on learning principles. They're called cognitive behavior therapy techniques. And that probably is the one that should be investigated by individuals with these problems early on in their search for a solution.
Yeah. In terms of medication, so far psychiatric medications, in what limited studies we haven't shown themselves to be particularly effective in treating this. I think where medications can be effective and helpful is if individuals have other conditions regarding anxiety, depression, other types of disorders like that, that these problems are maybe aggravating the BFRB, and by treating those with appropriate medications, we can sometimes take the pressure off the disorder itself, although they're not regarded as cures, but they could certainly improve the individual situation and leave them better able to work on these things and to make a recovery, basically. So people always want to know, what's the best medication and everything. I say, well, medication can only do what medication can do, basically. And you'll hear about all kinds of other treatments out there too. And, people will say, well, this worked for me, or another person will say, well, this other thing worked for me. And I always say that I have a saying. I say that everything works for somebody, but nothing works for everybody, basically. So I think it's a matter of ultimately, learning to tailor the best treatments to each individual, basically, which is, I guess, what precision medicine is really all about too, and what TLC has been actually working on these last few years. But I would say, in agreement with Charlie, that at the present time, that learning-based treatments are clearly the way to go, and I believe at the present time do produce the best overall results. Are they perfect? Do they work exactly the same way for everybody? No, but I would say that for the majority of people, I think they hold the most promise, given what we know right now.
Right. Those are some great points. And I think it's also important to point out that along the lines of precision medicine and treating each person as a unique individual, that if a person is struggling with depression or anxiety concurrently with a BFRB, it's important potentially to address those issues. And sometimes if someone experiences their BFRB in the midst of a depression or the midst of anxiety, it makes a lot of sense to treat that behaviorally or with medication. And so while we're not using the medication to specifically treat the BFRB, oftentimes medications can help with other concurrent conditions and consequently help with the BFRB. So I think it's, as you said, Fred, important to take each individual, to look at the individual before making that decision. So at what age do people typically start pulling or picking? Do we know?
Well, it looks like puberty is a particularly critical time for BFRBs to develop. There may be some differences between sexes, where the boys may start a bit earlier than girls in different ways, but that data isn't clear yet. We're still learning more about the details of this. However, it does look like puberty around age 11, 12, 13 are vulnerable times for these things to begin. If you're familiar with the standard normal curve, that bell-shaped curve, as you move away from the area of puberty, the onset of puberty, you find fewer and fewer people. As you get younger, fewer. As you get older, fewer. So that is a vulnerable time, and it's very interesting. Why should that be? And that's something that we're still examining. Is it something to do with the change in the physical self? Is it hormonal? Are hormones actually part of that? What about social consciousness? That's a time when children are particularly concerned about being appealing to their peers. And it may be social consciousness redirects the focus on the body. So it's very interesting to know that, and but to understand why and to translate that into useful information for learning to prevent or to treat it early. That's our next challenge, I think, to understand that better. Fred, pick it up.
Yeah, there's another form, or possibly another form of this, that is seen in the very young, basically in children as young as, I think, about 18 months, 2 years. That's over the years has been referred to as baby trick, basically, in which you see very young children, pulling hair or picking skin. And a lot of questions have arisen as to whether this is a separate entity. It's a separate problem with its own origins, kind of like thumb sucking or things like that, which you see, as an early type habit, or whether it's related to what we see in older people as well. It's a little hard to say at the present time, but it is a phenomenon that, again, needs a lot more study. We really, some people, do it briefly in their younger ages, and then other people, as they age, it sort of tapers off. Other people continue to do it, into puberty and beyond. I wouldn't say we don't really know how many people are affected this way. Maybe one day we'll be able to, again, with more surveys and more studies, we'll be able to get more information on this. But that may be another subgroup that's worth examining.
So one question that came up several times is about OCD and BFRBs, and there's a bit of confusion now that BFRBs are categorized as obsessive compulsive and related disorders. So can you guys kind of talk about, are BFRBs the same thing as OCD? Is it a form of OCD? Is it related to OCD? Kind of speak to that issue.
Yeah. This is a lingering difficulty, the association of BFRBs with OCD, but it has mixed benefits and liabilities. Okay, it's true that even the helping professions and psychological and psychiatric researchers were not sure of the relationship between OCD. There did seem to be a relationship. I'll get to that in just a moment. I will say that when I started doing some work with NIMH, National Institute of Mental Health, in an OCD program, at that time they were calling hair pulling, trichotillomania, monosymptomatic OCD. All right, so that was the citadel of medical knowledge, the National Institute of Health, NIMH, the subdivision with mental health, were still confused about that and did research that found out that the medications that they were examining at the time that worked pretty well for OCD didn't help nearly as well with BFRB. So that was their indication. I was working there and I had seen trichotillomania before, and I never believed it was exactly the same. However, research does show that OCD and BFRBs do run in families. If you find the presence of one of these two, there's a greater than chance probability that you'll find it in clusters of related family members. So we have that familial connections. The geneticists are telling us that as they get closer and closer to looking at the genetic basis for OCD and for BFRBs, they're finding similar genes or maybe identical genes that may be turned off or turned on by experience that may turn out to be OCD or the other. Originally, they were in separate chapters in the diagnostic manuals that people use. Now, they've been clustered together in the latest diagnostic manual by the American Psychiatric Association into BFRBs are brought into the fold as OC-related behaviors. And I think that's what we should call them. They're related to OCD in ways that look sort of compulsive in certain ways to certain individuals are preoccupied in a way that may seem to be obsessional, but they have their own characteristics, their own course of the way they develop and their own reaction to different kinds of treatment that suggest they are different. So I like to think of them as perhaps in the same stadium, but with OCD maybe in near home plate, BFRB somewhere in the stadium, and related, but not quite the same thing, maybe out in left field somewhere, like hoarding or something else that is similar to OCD, but not identical to OCD. And we have to appreciate the differences and clarify that, because many professionals still confuse the two. And that can discourage individuals seeking treatment who if they go to a person that says, oh, here's something that works very well for OCD, we're going to do this and get rid of your hair pulling or skin picking. Well, that is a problem. So we're trying to get, TLC in particular has gotten the word out. I think that a lot of ignorance about that has been corrected, but there's a lot more to do since there's still confusion.
Yeah, I would agree with Charlie on that. And I would say that, the way I usually describe it is to say that they're sort of like distant cousins, basically. And there may be genetic links between them. Again, it's hard to tell. We don't know enough about how these genes interact with each other or how they may express themselves. And it's still something that requires, I think, a lot more study and research. I mean, there are, some similarities, although some of the similarities could be just kind of superficial in that they involve repetitive behaviors. And I think a lot of in the past, a lot of disorders that had repetitive behaviors were sort of lumped together in the same categories. I've seen a lot of people, for instance, with autism who've been misdiagnosed as having OCD when in fact the behaviors were related to autism and all. And sometimes people try to characterize even BFRBs, some people with BFRBs as having tic disorders because some people's pulling and picking has tic-like characteristics. And we know there are links between tic disorders and OCD. So these things may be part of a whole constellation of disorders that are somehow interrelated in ways that we don't even understand yet, but are hoping to. So I think, that we still look forward to learning more about these. But I mean, there are a lot of, distinct differences too. And the OCD involves intrusive, repetitive thoughts of harm coming to an individual, or they're causing harm or damage to other people, and all kinds of negative things happening. A lot of superstitious thinking, things that you don't see typically in BFRBs. And I say there certainly are repetitive components, but again, not all people with OCD do repetitive things, and a lot of people with BFRBs don't do almost any of the things that resemble OCD. When I first started treating OCD about 40 years ago, people used to come to where I worked and claiming that they had OCD when in fact they had a BFRB, but they were all, again, just sort of thought to be identical back then. But now I guess we still, what I'm trying to say is we have a lot more to learn about these things.
Sure. Well, along those same lines, Fred, do BFRBs, this is a question that came up several times, do BFRBs lead to other more serious problems like cutting, anorexia, bipolar disorder, suicidal thoughts or actions? Do they lead to something?
We don't see these disorders as any kind of like a stepping stone to other things. I think a lot of times BFRBs have been mischaracterized as being some kind of self-mutilation or self-harm, but the patients that I have seen who do self-harm versus people who have BFRBs, they're distinctly different and do what they do for very different reasons and all. And I think what you see in BFRBs is a lot more sensory aspects to this, and in the other they're in the self-mutilation, self-harm, are more related to other types of psychiatric disorders. I mean, it's possible, yes, to have more than one kind of disorder and to develop one disorder, but it doesn't mean that one led to the other one. I mean, there's no rules about these things at all. So I would say that no, just because you have a BFRB doesn't mean that you're going to somehow develop something else. You would have to have some kind of a predisposition to have that other disorder to begin with. So I would say no, that's not the case.
To be clear though, are you differentiating between a BFRB and self-mutilation or self-harm as
Oh,
two?
yes, definitely.
Okay.
Definitely. Yeah, I do not see that those are the same entity at all, really.
Yeah.
I think people who do self-harm, are doing, as I say, for more reasons that are probably more emotionally related and are done for a much different reason than people are doing, in the case of BFRBs, which, as I say, are more sensory entities, essentially.
Well, and let's kind of ping off of that sensory, because a couple of the people in our community asked questions about sensory and BFRBs. And one of the questions is, how do I address my sensory needs when the part that feels the best sensory wise is the stimulation of the hair being pulled on the scalp? So in other words, how that question, specifically, as well as how do I address my sensory needs to reduce my pulling and or my picking?
Well, sense, as everyone pointed out, the senses obviously play an important role in BFRBs, both in terms of triggering the patterns. If a person sees a blemish on the skin, feels a bump on the skin, it may be the first step in a progression of behaviors that leads to the picking of the skin. The same thing with visual. If someone sees a hair that's out of place, an eyelash or an eyebrow, that is out of place, or one that might look appealing to pull because they may have a plump bulb attached to it. All of these things are triggers for the behavior, but they also serve as consequences. They provide some sensory feedback. So sometimes the sensation and achievement of getting something out of a pimple can be very rewarding for an individual, and that's sensory. One knows by viewing and feeling the differences. Smoothing out of skin is a desirable outcome to people who are bothered by scabs or rough skin on the feet or whatever. So we do know that that's the sensory aspect is an important part of BFRBs, perhaps more important in certain ways than it is for other disorders. However, it's only one of a number of, let's say, conditions or mechanisms that can lead to the pattern of skin picking or hair purling or related kind of problems. Sensory is important, but it's not everything. So, we should get into some of the other things, but I'll just simply say that sensory needs to be addressed by an individual. It helps us understand the kinds of triggers, the kind of things that establish the onset of a BFRB, and that serve as rewarding conditions that are achieved through the BFRB that provide sensory feedback, satisfying feedback. How does one deal with that? Well, that's many people love steaks, but they'll eat a hot dog if they're hungry. Is it the same sensory experience? No, it's not the same sensory. Is it entirely different? Not really. It involves many of the same, the same muscles and mechanisms and the taste buds and the satisfaction of the hunger. So we can find other ways of diverting ourselves from one sensory interest to another. We distract ourselves at times. At other times, we do something that's similar but not quite the same. We might really wish we had some chocolate cake, but we'll eat celery instead because that at least satisfies some of our sensory needs. So there are ways of substituting, of distracting from sensory needs, and finding other ways of being satisfied enough that the BFRB pattern is not necessary to achieve a satisfactory level of comfort without the damage. Yeah.
Sure. That's a great description of the sensory aspects of pulling and picking. I'm wondering if now would be an appropriate time to talk about the other aspects that you mentioned, that there are others, just so people are aware. I know we have a lot of people on this call who likely want to know what are the other things that we look at in treatment or that are relevant to different people for why they pull and why they pick.
Right.
Oh, sure. I think there are a lot of potential inputs that can impact on these disorders, along with sensory. Sensory, of course, is an important one, but it's certainly by no means the only one. For one thing, environment plays a role. In other words, some people only pull and pick in certain places at certain times of day under certain conditions or during certain activities. So that has to be looked at, especially when you're talking about coming at these things from a learning perspective. Basically, these behaviors can get attached to different things. Thought or cognition is an important area. Certain thoughts about, my skin has to look perfect, or this hair doesn't belong here, so certain ideas, or I have to look a certain way, can also trigger the behavior. So that's another input. There can be emotional inputs. I think of a case of a particular person I treated who every time they got angry at one of their parents, they would go off and pull to kind of calm their system down afterwards. So the anger of emotion triggered that person. But there's other emotions too. Some people, when they're happily excited, will pull as well to sort of just kind of level themselves out a bit. So there's that. Trying to think of some of the others.
Well, the one other that is pure habits, motor habits. Sometimes without even realizing it. Hands can sort of have a life of their own. And so an individual might be working on the computer or reading, and the fingers might be then traveling to find a particular aberration or a preferred spot or a preferred target for the pulling, a certain kind of hair, a sharp one, an out of place one, skin, a rough spot, a patchy spot. So these often there's a word that those of us who work with learning-based treatments use that help capture the 5 categories that we just mentioned here. Fred mentioned the sensory. He mentioned the feelings that may generate and be in some way be assuaged by picking or pulling. That's affective. There's cognitive, or the thinking process, somebody thinking that I have to get something out of this pimple in order for it to heal well, or it's awful if I allow this out of line eyebrow hair to be seen by others. They'll think I'm, so thoughts can drive it. Anyway, they put together with the word scamp, it helps. Sensory, cognitive, the thoughts, affective, motor, which are habits. Motor habits are muscular habits. So the way the postures we have, if I'm sitting here like this, I'm right at my eyebrows. And if I'm a traditional puller of my eyebrows, that's I'm already into the pattern, and then it's harder to stop than it is not to touch in the first place, right? And then finally the environment, that we just simply shorten it to place. The place in front of the magnifying mirror or in a brightly lit bathroom. These can be highly likely environmental triggers. So SCAMP, S, sensory, C, cognitive, A, affective, M, motor, automatic habits, and P, place or environmental factors. They help us remember that there are very important inputs and satisfiers that keep these patterns going. And if we're going to help a person stop that, or if a person is going to stop themselves, they have to find some other way of dealing with the inputs that may be provided from usually several of these categories.
Well, and thank you for that, both of you. That's a beautiful overview of kind of the different areas that we look at. And we've got some questions from our community members that are specific to dermatological or physiological conditions. One being, have you come across any patients with trich that also have been diagnosed with lichens planus pilaris? How does the lichens relate to the urge to pull? Is it because the lichens that the patient is pulling? And so I wonder, using that model, is there a way to think through that specific question that could be answered by the model?
I would, if I can just say something about that. I think when you have a predisposition to one of these disorders, I think anything that sometimes appears as different or out of place can become a target for these kinds of behaviors if you're prone to doing these things. So it can be any irregularities in your skin, anything to do with hair growth or texture or thickness of hair, and there's many different disorders which certainly can create these conditions in a lot of different dermatological conditions, which then sort of become the target of the behaviors. But although sometimes you see people who have nothing like this who actually create things like wounds on their skin or scabs or things that they can then pick and pull out, or it starts with an insect bite, for instance, that they scratch and then scabs over, and then it gives them something to pick. So it can be anything, really. It could be a disorder, it could be something naturally occurring, or it could just be something that the person creates themselves just for lack of something to pick at, basically. But so again, I think each individual has to be looked at as a case of one, basically. But I think it's also safe to say that a lot of things can be drawn up into these problems.
Okay. Thank you. So next question. I've had OCD since I was 10. I'm 36 now and haven't had a BFRB until 3 months into COVID. I started pulling my hair and now I'm bald. Is there more of a possibility of developing a BFRB, or was it already an underlying trigger? I'm just wondering why now. So it sounds like this person had OCD and developed a BFRB into COVID, which obviously was very stressful for many of us and isolating. And could there be that this was waiting to unfold, or how would you guys explain that?
Yeah, well, COVID exacerbates a lot of problems, right? And we know now that there are more people seeking mental health assistance than perhaps ever before. So why is that? Well, COVID has dampened our lives. It's put a cold blanket over a lot of things. We haven't been able to get the same sources of satisfaction, the freedom to come and go, to do whatever we feel like, particularly the importance of our social relations and so forth. So our life has been, our sources of satisfaction, stimulation have been in a sense choked off, we're more narrowed. Even now, we're dealing with one another as, you know, two-dimensional squares on a screen. When we're together, it's a whole lot different. We are able to touch and experience in a three-dimensional way and move around, and all of that means that there perhaps are needs that are unaddressed during episodes, this extended episode of isolation and limitations. So I would say that. Also, there are problems that are associated with COVID, and problems cause stress, and stress causes arousal, and arousal can feed many things, including BFRBs. Why this emerged during this person's isolation may be related to the OCD. We've already said that there may be common substrates, some original sources that can express themselves as either or both. It's not, though, a highly comorbid condition, OCD, and that doesn't mean for some individual. That means that there are not all that many people with both OCD and skin picking as compared with, say, anxiety or of other sorts, or depression and other sorts. So they're not automatically, you know, fist and glove together. However, if a person is vulnerable, it may be that they are vulnerable in more than one area. The combination of the stressors and limitations of that COVID had placed upon us perhaps caused more disruption in the nervous system that became the fuel and that was channeled in the direction of the BFRB. All we can do is speculate. We're happy that it doesn't happen to large numbers. All the people with OCD are not now developing skin picking or hair pulling. We're sorry that these things do happen for some individuals, but we can look at it more like certain individuals with depression have become more depressed. Some people who were never depressed became depressed during COVID. Anxious, the same thing. Probably other kinds of disorders. Addictions, we know that they're impacted by COVID as well. So what I've done is sketch around and saying that these things are probably not so closely related as cause and effect. And it may be a bit mysterious because we don't understand the relationship between these disorders, but it doesn't seem to be so common, at least evidence up to this point, that one will sort of turn into the other or beget the other under conditions of stress.
Thank you, Charlie. I'm going to race through these last few questions because I want to make sure we get to all of them. Can you please discuss why or how someone can experience their BFRB when they are alone, but when they're around other people, even if it's a high stimulation or low stimulation environment, they don't? Is it peer pressure to act in a typical or normal fashion and not to pull or pick? So great question. Fred, any thoughts on that?
Yeah. You know, I don't think we should underestimate the power of social pressure, basically. And I know plenty of people that I've worked with over the years who would, you know, work their behavior furiously when they were isolated or alone, but when they were out in public, could not do it because the particular way that they perform their behaviors would have made it so obvious that they would have drawn a lot of unwanted attention to themselves and only increased their sense of, you know, shame and embarrassment, which we know, you know, is a part of these problems. On the other hand, I have also worked with some people who were particularly smart about it and could actually carry out the behaviors in the presence of other people without being detected. I've had people sit right across from me who were actually actively pulling hair, and unless they told me they were doing it, I would not have detected it, because that's how good they became at it. So I think you see both things, actually. There's it's like even with like tic disorders, for instance, people with like Tourette's, for instance, can, under certain circumstances, withhold a tic for a while, but then have to go to some other environment and let it out where they won't be observed later on. I've seen that in some patients who have these disorders and tic disorders as
Sure.
well. So it's not inevitable that you must do it. People have some level of control over it, maybe not as much as they would like, but yeah, there is that element.
Yeah.
And that's not just with BFRBs or any particular and any disorder. This sign of socialization, of being a socialized individual in a civilized society, is that we gear our behavior to those who are present. We talk differently to our friends versus to our bosses. We dress differently for different occasions. So we gear our behavior to the situation. We eat differently at a carnival than we do sitting at a full course dinner, in a proper setting. So again, as Fred pointed out, the power of social, of the influence of social impact is great across the board in people. And because of the shame, and let me underline that, because Fred's mentioned it, it's only the first time. It should be kind of elevated like a big balloon. Shame is part of this disorder, which means that people don't want to be seen in many cases doing this because of that shame. And the shame is that no one else does it, and people are going to think I'm awful if they know I do this. We have to break that degree of shame. Most of it is unwarranted because these people didn't ask for it. They can be very important and quality individuals in their own right, but happen to pull hair for reasons that are not entirely clear, but maybe biological and experiential. So that's another point. The importance of social impact. Isolation is one of those conditions that is a place variable. Be very important for individual. We can use that in therapy. If a person studies instead of a study carrel where they have privacy and pull out their hair, if they study in the main reading room where they're less likely to move their hair, hands to their face and skin and do these kinds of things, that can help control one of the inputs to the
Sure.
hair pulling. So if we find enough of those, we can maybe weaken the problem and divert it into healthier care of the skin and scalp and hair and so forth.
That's a great point. And there are a lot of questions that have come in about parenting and from the child's perspective or adult child's perspective, as well as from a parent's perspective. And I wanted to mention that Ruth Gollum and several different parents in our community will be talking later today and can address some of these questions. But one that came through that I just want to mention to you guys is my parents tell me to stop pulling all the time. And it makes me pull more. How do I tell my parents that hearing just stop it makes my pulling worse? And the reason I bring this up is because I think it speaks to the shame and how parents are able to help their children not develop that level of shame in terms of how they speak to their children and deal with this issue along the way. So I will throw that to you guys.
If I can say something, I think that a message that I always give to parents is that you don't control your child's pulling or picking. They are the only ones ultimately who can control it. Just telling someone to stop is pretty useless and will put a lot of pressure and stress on them. And of course, that's only going to feed back into the system and create more pulling and picking so that the person can then sort of, calm themselves emotionally for having been pressured by their parents. So this does not work. I think getting your child the kind of help that they need and giving them the skills and the knowledge that they'll need to help themselves and to patiently bear with them as they're learning these things is going to make an awful lot of difference. But simply, when even my adult patients tell me that this was done to them as children, and their answer always is, well, don't you think I want to stop? Do you think I really want to do this? I mean, it's telling somebody, well, why don't you just stop is I think a lot of people regard these things as just bad habits. And if it was pointed out to the person, they would be able to stop it. but it doesn't work that way. Basically, the person's really taking on their whole nervous system, basically, and that's for a kid, that's a pretty tall order. I mean, it's even a tall order for adults to stop. So to expect a child to just stop because we told them to
Right.
stop is pointless.
If they could, they would. I mean, if we could, we would. Okay, last question, and then we're going to wrap up.
Just will say one thing about that. Those parents who they're trying to do the right thing. They're trying to do the right thing. They're trying to help their child stop a pattern that is quite disheartening. However, let them, each individual, let all of us think about how easy it is not to cough when you have to cough. Not easy how it is not to sneeze when you have to sneeze. These are powerfully driven behaviors that have a history to them and an experience to them that we know that only one thing will end that discomfort or restore a certain sense of balance, and that's the way BFRBs function, to restore a temporary sense of balance that is ends sometimes very powerful urges and other feelings that want only this behavior. So not so easy to stop. And I think we all need to remember that at times. Yeah.
Great point, Charlie. Okay, last question real quick. This is from a person in our community who's been pulling for about 35 years. And it's pretty severe. Worried that scalp is damaged beyond self-repair. Is a hair transplant something you would recommend, or are there other options?
Personally, I would not recommend hair transplants until the person's condition is under control, basically, because there's always the danger that the person's going to go through these expensive and uncomfortable procedures and then turn around and pull out the hairs that have been transplanted. So, I think it's kind of putting the cart before the horse, so to speak. I think first, a person has to achieve a recovery, and then they might consider that, if that's true. Some people actually have never stopped pulling long enough to find out whether the hair would grow back or not. And sometimes when you pull hairs, it kind of shocks the follicles, and they go into like what we call like a resting phase, and it can be months before a hair grows from that follicle again. So people are continually pulling, and even as a new hair starts to emerge, pull those out. They just set up this cycle, so they never, as if they stop doing it long enough to find out what would actually happen if they weren't pulling. So it might be that even a transplant might not be necessary. For a hair to never grow back, you have to really do a lot of damage to the follicle, which is actually pretty deep under the skin, basically. I mean, it is possible to do that, especially people who pick at their follicles with instruments and various things, or cause infections and things like that. But generally speaking, I mean, for the most part, hairs do grow back.
I would say too, the same question comes up with wigs. Should a person get a wig or a hairpiece that covers it? And the answer is that there's probably no one answer for everyone. That there is potential for a double-edged sword here. It may cause more problems because it's hidden. The person may feel it's okay to pull out the hairs underneath and therefore be well practiced. Some people even pull from wigs that they bought. So it has to be conceived within an overall understanding of where the person is regarding their BFRB and what their goals are for using these devices, whatever they are, whether it's a medical transplant or whether it's a wig, a hairpiece, or whatever, or tattoos for eyebrows. They all have to be looked at in the bigger picture for this individual, rather than deciding they are a solution for all.
Well, that is about the most amazing question and answer I've ever heard on BFRBs. You guys are awesome. So on behalf of the TLC Foundation, I'd like to thank Dr. Mansueto and Dr. Penzel for your time and dedication to the BFRB community. We are so grateful for you and for everything that you contribute today and always. We're thankful to the TLC staff for putting this event together, and to all of you for tuning into this important community conversation. Thank you. We wouldn't be a community without you. To all of you attending today, thank you. Don't forget to help us by completing the post-event survey, which is now linked in the chat. Completing a post-event survey enters you into the drawing for a BFRB Brave box valued at over $150. Also, get registered now for the BFRB Awareness Week events. There are 5 more events over the next few days. There's something for everyone. You can learn more on TLC's event page, and that link is also now in the chat. It's not too late to wear your BFRB pride. Order your BFRB Brave merch today through Bonfire. 10% of every sale is donated back to TLC to support programs just like this. And that link to the BFRB Brave merch is also now in the chat. And finally, if you enjoyed attending today, please consider supporting TLC by making a donation. This helps us continue to offer programming like BFRB Awareness Week and much, much more. You can make a donation now at bfrb.org/donate. Thanks again for joining us, and we look forward to seeing you all hopefully very soon.